Hello, everybody. My name is Eduardo Schemberg. I'm Brazilian. So, following up on Janice, I'd like to say a little bit about myself. So, in Brazil, I would say that I'm middle class, white, privileged. But maybe here, I might say that I'm a minority because I might be seen as Latin American. And also, please bear with me that I'm not speaking my native language. I'm speaking a language that I started learning at 12, so I might face some bumps here and there, but I hope you all be able to understand. Also related to psychedelics, I'm trained by Stan Grof in the holotropic breathwork. I'm a certified facilitator. I'm trained by MAPS in the MDMA training, and I'm director of Instituto Faneros, a small non-profit in Brazil, leading the first psychedelic-assisted therapy research training program. We currently have 50 students, and we hope to have 150 next year, and to treat 220 patients, both with MDMA and psilocybin, in collaborations with USONA and MAPS. What I'd like to discuss with you today is the relationship of ethics and epistemology. And the key point of my talk, I want to say right up front, is that I don't think we can solve ethics if we don't get epistemology right. Okay? How do I pass the slides here? Okay, got it. So I declare I don't have any financial conflicts of interest, and I also want to state that I will not be addressing the boundary violations and sexual harassment and abuse that have been going on. Not because these are not important or I don't care. I think they're super important, and I'm glad to see they being addressed here by different speakers. But because the focus of my talk is not on the ethical problems that happen when the norms and principles and guidelines are disrespected, but of ethical challenges that are born within the biomedical canon. So when we do the research following the biomedical principles, what are the tensions and ethical challenges that we face? So the first big question, I think, for us in this conference and others is, does psychedelic therapy work? Right? This is, everybody's interested in this. And these are just 4 recent papers of psilocybin, MDMA, LSD, different psychiatric conditions, all of them, one phase 3, the others phase 2, their new phase 3s starting. All of them seem to come to a common conclusion that yes, we have maybe preliminary signals that this therapy work. And then the next very important question is, if this treatment work, how can we know it, right? This is the domain of epistemology. How do we develop knowledge? And all of them seem to agree as well that we know it by conducting double-blinded, randomized trials. So not focus on randomization in this talk. I think randomization is pretty clear, its relevance, its methodological importance, and we don't have a specific issue related to randomization and psychedelic drugs. But we do have specific issues related to psychedelics and double blinding, right? And I would like to go deeper into this. Like, what are the things that are going here? When we look at these papers, it might give an impression, especially from someone looking from outside the field, that we are finally getting into a consensus. Okay, the double-blind studies that were not done in the 50s, when this methodology was becoming the gold standard that it is now. So we're finally reaching this consensus, and this will move us toward approval of new therapeutics, new drugs. But it's not quite like that. Let's welcome dissent, right? There are people saying go slow on psychedelics, others claiming that psychedelics are the new psychiatric craze, people discussing hope and hype, challenges benchmarking MDMA therapy, and people calling attention to the explosion of a psychedelic hype bubble, right? I personally want to welcome all the dissent. I'm here as a dissenting voice as well, related to the double-blind method. And I hope you see in the remaining of the talk why dissent and diversity are fundamental for the progress of science. So I published in 2001 a letter to the editors with this title, Who is Blind in Psychedelic Research? In response to the first paper in this slide from Suresh Muthukumaraswamy in New Zealand, who were the first to publish a very good paper showing the problems with high rates of unblinding, right? So the protocols are double blind, but the results of the studies are unblinded because people, because of the very effects of psychedelics, they can easily correctly guess their treatment allocation. And many speakers here discuss the tensions and difficulties related to this. And the other papers build upon this. And what they bring is like, we have drug effect, we have therapeutic alliance, we have spontaneous healing, we have all these things, expectancy, right, and patient beliefs that are said to be biased, right? So these studies, the critics say the studies are biased. The more harsh critics say the studies are not valid, or it's not possible to interpret the results if blinding is not successfully, if it doesn't successfully result in a blinded study, right? But the problem is that we all know that there is massively unblinding here. And just think about a meta-analysis, which will put unblinded, double-blinded studies on top of non-blinded open-label trials, which epistemologically speaking, it doesn't make sense. So perhaps we could do a minute of silence to all the evidence-biased meta-analysis that we're collectively building by writing these papers as if they were double-blinded and not reporting the results and not assessing and not reporting these blinding conditions, right? So going deeper into this, let's discuss a bit what evidence-based medicine philosophy tell us about both the legitimacy of a placebo condition and what are the requisites for something to be classified as a confounder in a clinical study. So first about placebo legitimacy. I don't know why I got 5 1s there, but it should be 1, 2, and 1, 2, 3. You can get it. So the first condition for placebo legitimacy is it should be a pill or a capsule or something, another drug, which contains all the relevant non-characteristic features of the test treatment. Before I follow to the next part of the sentence, it's already a bit strange. What would be the non-characteristic features as compared with the characteristic features, and how can we discern those? And the definition goes even more and say that these should be to the same degree that they are present in the experimental treatment process. So think about low doses as a placebo control. Are all the characteristics and non-characteristics compared to the same degree? I don't think so, because we have dose-response relationships, right? So low doses would not fit as a legitimate placebo condition. The second condition is that it has no additional relevant features over and above the non-characteristic features of the experimental treatment. Then think about all the other drugs that are being tried as active controls in psychedelic trials. Do these drugs fit this condition of having no additional relevant features? Again, the answer is no. So apparently no one in the planet was able up to this point to develop a legitimate placebo condition for psychedelic studies. Now, when we get to confounder requisites, what we have is that it must potentially affect the outcome. That's easy. It should be unequally distributed between experimental and control groups. And the last one, and more importantly, a confounder is unrelated to the experimental intervention. Now, if you're thinking about drugs, therapeutic alliance is a confounder, it's a bias. But if you're thinking about psychotherapy, therapeutic alliance is a factor. It's a component of the treatment, it's part of it. It is related to it. So again, maybe we are misclassifying many things as biases, while we should be actually talking about factors. And think about psychedelic-assisted psychotherapy from a more pluralistic perspective, where we have many factors, and if you want, you can think about a sort of mathematical equation, and you could try to track these factors over time and how they interact with each other. So does blinding matter, right? And we have pretty much the field split in two. On one side, we have the normative drug approval regulatory agencies saying you must do a double-blind study, but you don't need to report if it was blinded or not. These are the current rules, like the consort rules for reporting trial results does not demand nor require, not recommend people to report if the study actually ended blinded or not. And then we have on the other side the dissenters. And the dissent right now in the 2020s is very similar to the psychedelic dissenters of the 1950s, who disregard the clinical outcomes that are being reported because the studies turned out unblinded. So we need to discuss if the scientific consensus on the one side of the regulatory agencies and the dissenters on the other side, if they are normatively appropriate or inappropriate, and if they're epistemically appropriate or inappropriate, right? So how is this situation compared in psychedelic studies to non-psychedelic studies? These are 4 very interesting papers that looked to this formal reporting of blinding assessments in many, many studies. The first one, on the upper left, they randomly chosen 300 clinical trials, double-blinded, randomized clinical trials out of 10,000. And what they found was only 8% of these studies in all areas of medicine reported assessment of blinding conditions in incomplete form. That's really a shame for something that's called the gold standard. Then in their second paper in the upper right, they contacted the authors of 276 papers who did not report blinding assessments. They only got answers from a bit less than 50% of these authors, and they found that 40% did assess blinding violations but did not report in their papers. A different group in the third paper, they came out of a 10,000 database. They systematically filtered this to 300 studies, and including 70,000 patients. And 5% assessed blinding, and just 15% of these authors replied to emails about this issue. And the fourth study in this slide, 154 antidepressant clinical trials in the last 20 years, just 7% assessed blinding. So the conclusion is that the psychedelic clinical trials field is not methodologically poor, as some critics have been arguing, when we compare this with general biomedical practices. So either we try to improve the whole field, or we fall into double standards of accepting some drugs that were coming from unblinded studies, while we rejected other drugs by the same very reason. Another thing that doesn't seem to be going very well in psychiatry is its results of safety and efficacy, okay? So on the left here, you see 220 drugs approved by the FDA between 2000 and 2010, monitored by 16 years. So every little stair there in one color is one area of medicine. And every time one stair climbs one step is because one drug in the market has a post-marketing safety event registered, right? And psychiatry rises before all others and rises higher than all others in light blue. And after 10 years of approval, 80% of psychiatric drugs have the FDA puts safety warnings for 80%. This 80% in psychiatry is twice the 40% in neurology and 4 times as high as in cancer. So yes, we do have more post-marketing safety events for psychiatric medications than other areas. And the plot on the right is a recent study compiling data from 232 clinical trials for the antidepressants for more than 74,000 patients. And what they're showing there is that the effects of antidepressants depend on gender, on the baseline severity of depression, and on age. Okay? And what you're seeing there is on top is the placebo response, and bottom is the drug response. And you can see that the shape of the plots is really similar, but the drug on the bottom is shifted to the left. This shows that the drug, yes, outperforms the placebo condition, but by a small margin, right? So we do have lots to think about improvements in psychedelic trials. And then my big question here is, if double-blind is not serving its epistemological function of controlling for biases or factors, what role does double-blinding serves in medicine? And there is this very interesting 1993 paper by an MD from Washington where he says that placebo controls serve an epistemic control function in orthodox medicine. And I'll read a part in blue from his abstract. This is what he says. The blinding necessary for a proper placebo-controlled RCT introduces an epistemic bias into orthodox medicine. Therapeutic successes that rely upon a direct link between knowing and healing, such as placebo effects, are discarded in favor of therapeutic successes that rely upon an indirect link between knowing and healing, such as pharmacological interventions. So this is key, and to unpack this, I want to go a bit deeper into the philosophy of science with two amazing books, one which is already a classic by Miranda Fricker from Oxford, Epistemic Injustice, Power and the Ethics of Knowledge, and the other very recent book by Michela Massimi, President-elect of the Philosophy of Science Association for the next 2 years from University of Edinburgh. And I want to read a bit of what Michela brings to us in his book, Perspective of Realism, because I think it's really precious for the field of psychedelic science and medicine. So just quote her a bit here. Actually more than a bit, because she writes very well. So here's what she says. From within the history of science, a different flavor of realism about science is within our grasp. I ultimately want to celebrate scientific knowledge as a distinct kind of social and cooperative knowledge. Knowledge that pertains to us, wonderfully diverse human beings occupying a kaleidoscope of historically and culturally situated perspectives. Scientific knowledge becomes knowledge whose reliable production is not the prerogative of one single community at one historical moment. If ever there was anything miraculous about successes of science, it is not the success of an individual scientific theory T in latching onto a mind-independent world. It is the success of our human species in building over time an extraordinarily varied and reliable knowledge of the world we live in. Then what she asks us to do is to acknowledge the role of the human agent in science discovery and practice, because there is no view out of nowhere, right? So when we do that, we recognize that, quoting her again, each epistemic community relies on its own experimental, theoretical, and technological resources to source the relevant data and to reliably make these claims. So let me try to give you some examples pertaining to psychedelics. One, pharmacologists might rely on receptor binding and blocking studies in cells, in lab animals, in humans, in patients. Neuroscientists might rely more on neuroimaging, on entropy measures, or many other possibilities there. Psychiatrists would rely on standardized symptom rating questionnaires, but they are all looking to the same kind of phenomena. Now back to Massimi. She says, moreover, each community uses second-order methodological epistemic principles to justify their reliability. So this is very important. It might be difficult. I'll try some examples again, right? So she's saying, first, there are methods and data, and second, there are the justification of the reliability of the data obtained by each epistemic community. So some examples here from biomedicine. What are the second-order justifications? Objectivity, randomization, and double blinding, right? But how about the psychological perspective? Can it be objectified? And I will say no. No, because what lies between drug administration and symptom reduction are not just receptor binding affinities and entropy measures, but actually self-aware human agents, full of purpose, expectancy, beliefs, and behaviors, right? And none of us is out of the human mind to try to be objective about it. So going back to Michela, she says, the reliability of the knowledge claims advanced through data-to-phenomena inferences within each scientific perspective needs to be cross-checked and cross-validated. It's not one scientific perspective on top and the rest on the bottom, as evidence-based medicine tries to do with its underlying reductionistic approach. So in other words, we need a pluralistic approach to cross-check the data from pharmacology, psychology, social sciences approaches, races and social issues and so on, right? So Massimi concludes, the pluralism of scientific perspectives is not just a desirable methodological feature of science. It is not just a way of offering a menu of different explanations for the same phenomena. It is a way of checking the reliability of each data-to-phenomena inference within its own perspective in light of other scientific perspectives. Only in this way can key justificatory principles of each perspective be monitored, cross-checked, and held accountable, right? So I think this is very important. And now moving forward and connecting perspectival realism with epistemic injustice, this very powerful concept by Miranda Fricker, when she's widely quoted by saying that epistemic injustice is a situation when someone is wronged in their capacity as a giver of knowledge. And in her book, she talks about two basic types, the testimonial and the hermeneutical or interpretative. So these are injustices committed to people by not trusting their testimonies. It might be people of color, it might be indigenous peoples and their plants, it might be even patients and their interpretations of their own disorders and their own process of recovery. And Massimi extends these concepts of epistemic injustice in her new book this year with these two very powerful concepts of epistemic severing and epistemic trademarking. So if I don't get lost here in so many sheets of paper, and if you bear with me, I'll read Massimi a bit more. So she says, epistemic severing is the almost surgical excision of the contribution of particular communities from narratives about scientific knowledge production. Epistemic severing damages and jeopardizes the very possibility of understanding the processes through which scientific knowledge becomes possible over time. Now, about epistemic trademarking, she says, is the subsequent fencing and ultimately often merchandising of portions of scientific knowledge as a trademark of one epistemic community at the expense of others who have historically contributed to such production. Epistemic trademarking is first and foremost a structural phenomenon of how scientific narratives, or a particular kind thereof, get off the ground and tacitly enter public discourse as a result of specific epistemic norms that codify scientific knowledge production in particular societies. The epistemic trademark shows its efficacy by branding bodies of knowledge as epistemic goods that can be easily recognized and commodified for the use of a particular consumer audience. Sorry, I lost myself in the paragraph here. And then she says, at the receiving end, there are ethnic minorities and local communities whose local knowledge, often orally transmitted from one generation to the next, is particularly vulnerable to these types of epistemic injustices. Indeed, epistemic trademarking is the very epistemic mechanism that structurally underpins the phenomenon known as biopiracy, which has been defined as the unauthorized and uncompensated taking and use of biological resources for valuable research purposes. Whew. Thank you, Michela. That's really brilliant. And earlier this year, I published with another Brazilian friend and lawyer this paper about overcoming epistemic injustices in the biomedical study of ayahuasca. And in this paper, we have shown how indigenous people have been discriminated and how science loses important knowledge on doing this injustice against indigenous people. So just consider that after 40 years of ayahuasca research, we have not looked at the botanical and pharmacological diversity of plants that compose the many ayahuasca preparations. We don't have any scientific recipe on how to prepare ayahuasca that might guide prescriptions for ayahuasca to be used as an antidepressant. So scientists just get this beverage ready-made. They don't know how it was done, and they don't know how to do it themselves, right? And finally, which is very curious, we have qualitative studies for many psychedelics out there, the phenomenology, the mystical experiences. And if you look, as I did, ayahuasca is the one with the less of this type of information. So the experiences of the patients having ayahuasca to treat their depression has not been considered and has not been published and is not being discussed. As again, if we were talking just about the drug and phenomena in the brain, forgetting the people in between. Then another paper that we published, including here a Mazatec historian from Huautla de Jimenez, the town of Maria Sabina, where I already visited and had mushrooms with them as well in sacred ceremonies. We published this paper about ethical concerns about psilocybin intellectual property about 2 years ago. It was viewed online, I think, more than 20,000 times now, including, for my surprise, by Michela Massimi. So this is a funny kind of closing story here. I read Michela's book some 3 months ago. I was mind blown. Like remembered me my first ayahuasca session 22 years ago in a church in Brazil. And Michela came for the first time to Lisbon, where I live these days, to give a talk in a university. And I saw that online and I said, wow, I'm gonna meet her. This is so cool. And then I went there, we talked and we discussed, I made some questions and we went out for coffee. And while we were drinking this sacred Amerindian medicine, who now is a global commodity, we discovered by our mutual surprise that Michela is using this exact paper about psilocybin, the ethical challenges of psilocybin intellectual property, in her classes of science, philosophy, and policy at the University of Edinburgh, because she thinks this is actually a very relevant living example of epistemic severing and epistemic trademarking and how science can be improved if we just broaden our horizons a bit and embrace the richness of perspectival realism. Whoops, back one. So I have 30 seconds and I'll try to do this on time. On the left you can see the canonical evidence-based pyramid, right? RCTs on the top, of course, they should be double-blind, says the canon, and then observational studies in the middle, and expert judgment and mechanistic reasoning on the bottom. And what I'm proposing here is that perspectival realism gives us enough flexibility to say, yes, we do need randomization, We do need clinical trials, we do need rigor. We want to do this ethically, but less hierarchically, considering that we are dealing with a multidisciplinary field that is not just pharmacology on the top. It also includes psychology, neuroscience, agency, purpose, phenomenology, and how all these fields interrelate to each other. And to close with Michela again, she says, seen through the lenses of perspectival realism, science serves the needs of a multicultural, scientific world citizenship that can legitimately reclaim as its own the cosmopolitan right of sharing in scientific advancement and its benefits. But that carries also cosmopolitan obligations in ensuring no one is deprived of such a right, and remedies are in place to address stark inequalities in the historical access to scientific knowledge and its benefits. Thank you very much.